Welcome to the simulation. We are bypassing the standard introductions to engage directly with an advanced mixed-block clinical scenario calibrated specifically for top percentile performance. Today's agenda requires us to navigate 3 high-variance clinical modules. We will analyze colorectal neoplastic genetics, intrinsic renal pathophysiology, and neonatal hepatobiliary kinetics. The objective here is strict mechanistic deduction. We will master intricate physiological mechanisms and isolate pathognomonic markers to flawlessly execute multi-step management algorithms under pressure. Module 1 begins in the gastrointestinal tract. We start by examining familial adenomatous polyposis, or FAP, and the concept of the prophylactic mandate. FAP is driven by an APC mutation, carpeting the colon with thousands of adenomas. Given the absolute carcinoma conversion rate, prophylactic proctocolectomy is mandated. Contrast this with Lynch syndrome mismatch repair deficits like MLH1 or MSH2. Few polyps develop, but they rapidly progress to carcinoma. Because the DNA mismatch repair defect is systemic, patients carry a strict surveillance mandate. They require concurrent, rigorous screening for endometrial and ovarian cancers. Finally, we examine Peutz-Jeghers syndrome. This condition results from an underlying STK11 mutation, generating an extensive network of hamartomatous polyps across the GI tract. These internal hamartomas present alongside highly specific mucocutaneous signs, hyperpigmented macules appearing directly on the lips and buccal mucosa. Let's apply these clinical profiles. A 24-year-old female presents with a family history of colon cancer at age 40 and endometrial cancer at age 45. Her current colonoscopy reveals exactly 3 polyps. The clinical question asks, what is the exact underlying molecular defect? The options are APC, MUTYH, STK11, SMAD4, or a mismatch repair gene mutation. We can immediately eliminate the APC and MUTYH mutations. This patient has only 3 polyps, completely lacking the thousands of adenomas required for FAP or MUTYH-associated polyposis. We also eliminate the STK11 and SMAD4 mutations due to the absence of hamartomas, hyperpigmentation, or juvenile polyposis symptoms. This confirms a mismatch repair gene mutation is the correct answer. The specific combination of early-onset colon cancer, a very low polyp count, and a family history of endometrial cancer perfectly describes the Lynch phenotype. Determining the exact DNA repair defect is the ultimate pivot point. It dictates whether a patient undergoes immediate colon removal or requires lifelong multi-organ surveillance. Moving to Module 2, we examine the kidney. Differentiating the causes of intrinsic acute kidney injury relies entirely on identifying specific microscopic signatures in the urinary sediment. Consider acute tubular necrosis, triggered by profound hypotension or direct nephrotoxins. These insults cause epithelial cells to die and slough off. The necrotic debris forms pathognomonic muddy brown granular casts within the lumen, presenting with a fractional excretion of sodium greater than 2%. Now observe acute interstitial nephritis. This mechanism operates as a delayed hypersensitivity reaction to specific medications. Its microscopic signature is an inflammatory infiltrate. You will see eosinophil and white blood cell casts inside the tubule, highly correlated with systemic rash and fever. As detailed in this NBME explanation text, acute interstitial nephritis is caused by a hypersensitivity reaction to medications, where eosinophils are often detected in the urinalysis. Treatment mandates discontinuing the offending drug. Let's test this presentation. A hospitalized patient treated with vancomycin develops a rising creatinine, a low-grade fever, and a diffuse rash. What is the expected finding on urinalysis? The options are muddy brown granular casts, red blood cell casts, broad waxy casts, fatty casts, or eosinophiluria with white blood cell casts. We rule out muddy brown granular casts. While vancomycin can cause ATN, this patient presents with a distinctly allergic clinical profile. We quickly eliminate red blood cell casts, which indicate glomerular injury, broad waxy casts pointing to chronic renal failure, and fatty casts tied to nephrotic syndrome. The correct answer is eosinophiluria and white blood cell casts, confirming the classic drug-induced AIN presentation. Spotting a single inflammatory cell type in the urine dictates a massive management shift, from merely restoring fluid volume to immediately halting a life-saving antibiotic. In Module 3, we transition to neonatal hepatobiliary kinetics. Here, the conjugation state of bilirubin is the absolute metric for surgical triage. We start with physiologic jaundice. A newborn's hepatic UDP glucuronylyl transferase enzyme is functionally immature. This enzymatic immaturity results in a mild, transient, unconjugated hyperbilirubinemia that peaks around days 3 to 4 of life. Contrast this with breast milk jaundice, highlighting the disruptive role of beta-glucuronidase found directly in breast milk. Beta-glucuronidase deconjugates bilirubin in the infant's gut. This massively increases enterohepatic reabsorption and drives prolonged unconjugated hyperbilirubinemia. Both of those mechanisms are non-surgical. The catastrophic differential is congenital biliary atresia, a fibro-obliterative disease of the extrahepatic bile ducts. The clinical presentation is defined by absolute red flag markers, conjugated or direct hyperbilirubinemia, accompanied by acholic pale stools, and dark urine. According to the clinical text, biliary atresia presents with conjugated hyperbilirubinemia and acholic stools. Definitive diagnosis occurs through exploratory surgery, moving directly to a Kasai procedure. Let's run the final vignette. A 4-week-old infant presents with worsening scleral icterus, pale stools, and a direct bilirubin of 4.5 milligrams per deciliter. What is the most definitive next step in management? The choices are dietary changes, reassurance, phototherapy, exchange transfusion, or exploratory surgery with intraoperative cholangiogram. We rule out dietary changes, reassurance, phototherapy, and exchange transfusion. Those treatments are exclusive to managing unconjugated hyperbilirubinemia. Exploratory surgery with an intraoperative cholangiogram is the only correct answer. It confirms the physical obstruction and clears the path for the Kasai hepatoportoenterostomy. The specific bilirubin fraction serves as the definitive triage metric, providing the final word on whether an infant is discharged or moved into surgery to salvage their native liver. We have analyzed 3 distinct systems. Achieving top-tier clinical performance requires abandoning basic pattern recognition in favor of strict mechanistic deduction. Identifying the exact DNA repair defect, visualizing a specific urinary cast, or isolating the bilirubin fraction dictated the absolute next step in our management algorithms. Apply this rigid, marker-based algorithmic framework to all future mixed-block clinical simulations to guarantee high percentile accuracy.